All right, good morning, everybody. Welcome to Pediatric Grand Rounds. Thanks to those of you who are in the room with me today. Thanks for coming, and all of you who are online. We appreciate you as well. Usual reminders, if you're online with us, make sure you're muted and you can type your questions or comments in the chat with everyone box, and I will be watching the chat. And now today I have the pleasure of introducing Dr. Linda Eckert, who has been on faculty at the University of Washington, primarily based at Harborview for 33 years. She's a professor in the Department of Obstetrics and Gynecology and an adjunct professor in the Department of Global Health. She joined the faculty at Harborview in 1992, and 2 years later, she decided to do an infectious disease fellowship and then rejoined faculty in 1996. For the next decade, she pursued clinical research studies on the impact of HPV in HIV-positive women. And then since the HPV vaccine was approved in 2006, she's been focusing on vaccine clinical trials and policy development, including working with the CDC on STI treatment guidelines, with ACOG, and with the World Health Organization. She also served as lead consultant for WHO on their 2021 guidelines for cervical cancer screening as part of the global effort to eliminate cervical cancer. So excited to have you here with us today. Welcome, Dr. Eckert. Thank you. Make sure this is on.
Yeah. Thank you. And thank you to the brave souls who came to the room, but I also completely welcome the online crowd, which is frequently how I attend Grand Rounds in my own department, so I'm totally on board with that. And I don't have any disclosures. So today we're going to talk a little bit about setting the stage. I feel I need to talk a little bit to pediatricians about the HPV cancers and epidemiology, simply because we're asking you to prevent a disease where you don't necessarily take care of the clinical outcomes of that disease unless it's potentially genital warts. And I think in general that's been one of the challenges with HPV vaccine and prevention, is that the outcome is 15 to 20 years down the road. We'll talk about the vaccine and including where we are. There's been some really new data that have come out very recently, and also about the big elephant in the room about vaccine hesitancy and all the questions certainly I'm being bombarded with now. And I feel, of course, you could give me a lot of advice on how you deal with vaccine hesitancy, since it's so much of your bread and butter. Throughout all of this, I'm going to weave together some equity issues, and then lastly, I'm going to end up on advocacy, talking about narrative approaches and peer-to-peer opportunities, and the changing landscape that we may be in the next few years for how we message and what kind of messages go out about vaccines. So first of all, just a bit about my perspectives. I was raised in Wyoming. I went to college at Carleton. I went to medical school in San Diego. And while I was in San Diego, my last 4 months, I went to Nicaragua. And I spent the last 4 months of my medical school in a clinic there. And that was extremely formative. And also I worked in Liberia, and I've had the opportunity to be in Kenya as a provider, in Malawi and Namibia on policy development. Worked in Brownsville, Texas at a border clinic when NAFTA was being debated, and then of course landed in Seattle. And so all of these experiences and information have definitely informed my perspective. And then whenever I talk about cervical cancer or HPV disease, I always want to acknowledge Henrietta Lacks, who was, I think most of us know her story by now, but a woman in Baltimore who had her tissue removed without her knowledge, that provided the basis for the HeLa cells and so many wonderful discoveries, including the HPV vaccine that has come from there. And lastly, I just will mention a bit about language. The majority of the people that I take care of with the cervix do identify as women, but not all. And I just want to take a moment to say I will use individuals who have a cervix or persons with a cervix and women in this talk, but the clear thing I want to say is that a cervix is a cervix, and every cervix deserves care. So, setting the stage. So these two triangles represent HPV cancers and their burden. And what I want to point out in this is that in higher income countries where we currently are, cervical cancer is still 65% of the HPV cancer burden. In some countries, the oropharyngeal has overtaken the deaths, and I'll speak to that in a minute. but there's still a bigger burden of HPV cancers on the cervix than on other body parts. Globally, it's massively weighted toward cervical cancer. And when we go on to talk about the WHO recommendations and the priority for vaccinating girls, even though I definitely am happy we have gender-neutral vaccine in this country, the global picture is such that because the burden is so high for cervical cancer compared to the other HPV cancers, that is why there has continued to be this recommendation, if you have to choose who you're going to give the vaccine to, give it to the people that have the highest burden and where you can prevent the most disease, which is at this point individuals with a cervix. So we talk about cervical cancer being preventable and that we already have the moonshot for this cancer, well, which is good since the moonshot probably has gone away, at least right now. But we know it's preventable because we know what causes it, how to find it and treat it, and yes, that vaccine that we're going to talk about. Yet it's still killing a woman every 90 seconds globally, and in the US every 2 hours. And the cases are continuing to increase with even more expected rises upcoming. The other thing I like to just do to frame this talk is talk about the intergenerational impact. We think of this as a disease that strikes individuals with cervix, but truthfully, as you all know, especially as pediatricians, when you take the maternal unit out of the picture, it's a profound impact on the children for potentially generations. This was a study that looked at the number of orphans that came from maternal cancer in 1 year in 2020 and found that 20% were from cervical cancer. And we know that when you don't have the mother, all of these morbidities tend to happen. Plus you create generational poverty because you're often taking out one of the major, if not the major, wage earner in a family unit. So I think it's really important to think about this as a intergenerational disease and not just something that strikes a single person who has a cervix. It's very expensive. In the United States, we spend a lot of money on cervical cancer. And globally, if you look at what happens, how much essentially women are worth, this was an estimation that Oxfam did that looked at women's contributions in both their paid and unpaid work, and estimated to be well above $10 trillion because the burden of unpaid work, especially that women carry globally, is so profound. And this is more than 3 times the size of the global tech industry. So here we have a cancer that is preventable, that's taking out these incredibly valuable units of a society, of a culture, of an economy. And we need to try to address that. The health economy team at WHO, when they announced their elimination effort, did cost effectiveness studies and found that for every dollar put into the economy for screening, if you added in the unpaid labor, you got a 26-to-1 return, which is an incredible public health investment and payoff if you think about it, 26-to-1. So I won't dwell on this, but I think probably most people in this are aware that WHO launched this wonderful thing, this cervical cancer elimination effort in 2018, and they set these interim targets to try to reach by 2030 to be on the way to elimination. And if we could reach these interim targets by 2030, then we would already have eliminated 30% of the deaths from this disease. This was a really bold move by WHO. They've never called for the elimination of a cancer. They've eliminated smallpox, guinea worm, etc. But they've also never called for the elimination of disease that strikes just individuals with a cervix. And so it was quite an equity statement and very bold. And the global health community got really behind it. But I'll talk a little bit about where we are in reaching these targets. What's pertinent in this crowd is that 90% of girls to be vaccinated by age 15 was the goal by 2030. As far as the inequities in cervical cancer incidence, this is a map that we see all too often for almost every disease, which is where's the burden. And here dark blue is the highest number of cases per 100,000 or the incidence of over 29. But some of these countries in sub-Saharan Africa, such as Malawi, have actually 70 cases per 100,000. And so it's quite a densely crowded time, especially in sub-Saharan Africa. But the most number of cases in the world are in India, simply because of their population, and they don't screen. And so that's where you have 100,000 cases a year, actually, is in India. What's also really important to recognize is the dual epidemic of HIV and HPV. The risk for cervical cancer among women living with HIV is 6 times higher. And I think that it's really important to realize that we're not going to really get to an elimination of cervical cancer unless we deal with the HIV epidemic as well, because of all of these reasons that HIV impacts HPV disease. Okay, so where are we in our country? We, of course, have our own disparities. And here, though, I want you to look at this numerator for incidence. We're talking about going up to 12 here per 100,000, and remember in Malawi it's 70. So there is a difference in scale, but clearly there is also a difference in incidence by state. A lot of this reflects which states expanded Medicaid and have better access to low-cost screening and then follow-up treatment for cervical precancer. But what's hidden in these U.S. rates actually are also more marked disparities. This is looking at racial disparities, and you can see here in Native and Alaska and Natives, again, the incidence rate here is up to 17. This is the highest group population in our country. Hispanic incidence up to 13, Black 11, and then Caucasian 9 to 10. But what also just came out in just 3 days ago, actually, in JAMA Network Open, was this wonderful study that gave not great news, but really well done study, looking at cervical cancer incidence essentially for the last 20 years. And they compared urban-rural cervical cancer disparities and found that initially from 2001 to 2012, as cervical cancer screening was getting improved, et cetera, rates decreased across the country. But from 2013 to 2019, in rural areas, we're actually seeing an increase of 25% incidence in rural areas of cervical cancer, and the highest increase is in white women, and I'll talk more about why that might be in a minute. And we're also seeing increasing mortality. They have a much harder time accessing treatment and getting to treatment. And so this urban-rural divide is quite marked, and it may get worse. Especially if more rural care gets cut. And some of the reasons include lower screening coverage that's been well documented, and lower use of colposcopy, biopsies, accesses to LEAP, all of those things in rural areas, but also lower HPV uptake in rural areas. And so because of this lower HPV uptake in rural areas, we may continue to see this disparity broaden as people age into the time when they'll get cervical cancer. So the other thing I just want to step back and say, of course, HPV causes 6 cancers. That in men, head and neck cancer is 81% of HPV cancers. And that actually now, when you look in this country, the estimated deaths in men in 2023 from head and neck cancer is 8,100. This is twice the deaths from cervical cancer. Cervical cancer is 4,200. And that 70% of these are caused by HPV 16. So I think this is a really important fact to tuck in your pocket, to bring up with every parent and every person. You know, the male impact in our country of HPV disease is actually killing more people than the female impact, because there isn't a pap smear for the throat. And we don't have good screening for it. We can't pick it up in the precancer stage and cure it. So, you know, this data is also pretty recent and I think really compelling. Okay, talking a bit about now prevention, now that I've set the stage. Condom use still remains globally the most common way to prevent HPV disease, because global access to the HPV vaccine is still not what it needs to be. And because HPV is spread by skin-to-skin contact, condom use isn't perfect. It helps a lot. This is also about the reduction you see with herpes because there's other genital skin-to-skin contact that happens during coitus, and so it's a 60% reduction. But also what doesn't get much play in the global public health world is the impact of male circumcision. There's been a really compelling data on the impact of circumcision and voluntary male circumcision for decreasing HIV. But there's also been several systematic reviews that have looked at the impact on circumcision of males for decreasing HPV disease in their partners if their partners happen to be female. And you can see this is the line of no effect that a lot of these studies in this meta-analysis fell to the left for protection, with cervical precancer having one study with protection but less robust studies. So I do think that this is also a tool that we have that really doesn't get much public health play, because I think the idea of doing an intervention on a male to prevent a disease in the partner is not as popular as doing the intervention on the male to prevent HIV in the male himself. That's, of course, just my opinion. So, of course, primary HPV, the best way we have to prevent it is the vaccine, and we all know you want to give the vaccine before people get exposure because it prevents disease, it doesn't treat disease. I would say that we need to consider HPV 16 in a league of its own. It causes 50% of cervical cancer globally, and I already mentioned the throat cancer. And the good news for this vaccine and for HPV in general for prevention is it's so genetically stable. Unlike COVID, unlike flu, unlike HIV, HPV 16 is incredibly genetically stable and geographically stable. So the same vaccine that works in Seattle will work in Zambia, and that's been true for 20 years. So that is really fortunate. We know that the HPV 9 vaccine that we use in this country also protects these other types of HPV, and together this is 90% of cervical cancer. But the other HPV cancers, such as anal, and I mentioned throat, penile, vulvar-vaginal, those are almost all HPV 16. So these other cancer-causing types are more just associated with cervical cancer. And of course, we have good evidence now for the vaccine long-term protection, and that the age reflects not only giving it pre-exposure, but what I also like to tell to people asking me questions is we give the vaccine at 9 to 14 because we get a better antibody response. That's why we can use fewer doses. And so it's not just about sex, it's also about when does it work well. And it works the best if you give it in that age group. And there are trials going on now to look at it down to age 6. And won't that be great when we get that data and we can give it at an even younger age and take sex completely out of the question. But it remains very expensive. And for a vaccine that's been out almost 20 years, it still is incredibly expensive. Now, if you have insurance, of course, you won't be charged that. But if you're paying over the counter, you have to pay for the vaccine and the fee to get the shot. It makes it out of the reach of a lot of people. But it is a superpower. I mean, if you think about what flu vaccine, we're so excited when we get a 50 to 60% match. Or RSV vaccine that we've been giving to pregnant women, which is also incredibly exciting because it can prevent 80% of the hospitalizations for RSV. Well, here we have this vaccine that prevents cancer, and it's working amazingly well. So this was just one of the studies. I'm not going to go through all of them, but this was a Scotland study. They started giving the vaccine in 2008, and in those women that they followed forward, they've seen 0 cases of cervical cancer. Australia is on their way to eliminating this cancer. Sweden's close behind. And so there is no doubt that it works. So because it works so well, and because there's been global challenges with vaccine shortages, there was really good studies put forward a few years ago to start looking at a single dose. And I'm not going to go through all of these studies, but I just want you to know there's a lot of them. I'm going to go through a couple of them. And this is actually a question that is being considered now by the ACIP in this country for the single dose. So the initial data that raised people's eyebrows came out of the original Costa Rica trial, where they looked at the bivalent in 18 to 25-year-old for the original licensing of the vaccine. And what they realized is, even though they had a really good vaccine trial and most of the people got 3 doses, there were some people that got fewer doses. And they thought, well, hey, let's look at those people that got fewer doses and see what happened to them. And when they looked at prevalent 16-18 infections, which is a way of measuring vaccine efficacy, because you cannot get cervical cancer unless you have persistent infection. So they looked at persistent infection with HPV 16 and 18, and they found there wasn't a big difference. And they looked at the vaccine efficacy for preventing cervical precancer and didn't see a big difference. And I do want to point out that this 82% efficacy is different than what I was just showing you, because this was a study done in 18 to 25-year-olds. That was the original study. So some of those people undoubtedly had already been exposed to HPV. So the take-home isn't the number in the 80s. The take-home is that the efficacy was equal between these doses. And then they looked at antibody levels persisting of HPV 16 through 11 years. And they found that down here is 1 dose, blue. So yes, it has a lower level than 2 doses or 3 doses. But the real interesting thing here that flies in the face of the typical prime boost idea of vaccines is that a single dose had really persistent antibodies, and that these antibodies actually are 10-fold higher than antibodies in people that are unvaccinated. So are these antibodies indeed enough? And this study has been continued to be followed. And we just saw in November 2024 at an international HPV meeting, 16-year follow-up, that showed that continued very high levels of seropositivity, and that there was a little bit of waning in the antibodies of 3 doses versus 1 dose, but it was very small. And that the conclusion was that it still remains exceedingly high, and it should have protection at least for 20 years and likely much longer, based on the decline of a single antibody. So then there was a randomized prospective trial that was funded by the Gates Foundation in Kenya. And here they used either a single dose of the nanovalent, bivalent, or a meningococcal vaccine was the control. And again, they looked at persistent HPV 16-18 and with a single dose, and found either the nanovalent or bivalent worked well. The vaccine efficacy was really high. This was the initial report at 18 months that was in the New England Journal. This was a second report at 3 years that showed that the vaccine was still working super well. And then we just again got an update in November in Edinburgh at this conference, and again showing extremely high efficacy lasting against 16-18 and also the other types. And so this looks very, very promising for the use of a single dose. We're all waiting on more definitive data, and I think this will hit the news, and so I want to just pique your ears to listen to this. This has been a multi-year study that started in 2017, funded by NCI, of 20,000 girls randomized to either bivalent, 1 dose or 2 dose, or nanovalent, 1 dose or 2 dose, and has a control group of epidemiologic surveys of unvaccinated women. This is done. They're collecting the data, and we expect the first reports out in May or June. So this large randomized trial of 1 versus 2 doses that's following people long enough to get efficacy data, I think will also be extremely important as we ask the question in this country, is 1 dose enough? But the rest of the world hasn't waited for this. WHO came out in 2022 with a recommendation that said 1 dose is an option if countries want to consider it. So far, here the red is the countries that have jumped on board with 1 dose for 9 to 14-year-olds. Again, remember, this is 9 to 14-year-olds, the group that make the best antibodies. 67 countries have moved to single dose, including a lot of high-resource countries like Australia, UK, Canada, Spain. And so I think this is a coming trend, and won't that be amazing to only have to give a single dose of a vaccine, and what that can mean for the ability to get good coverage. One of the things that's been a well-kept secret is how hard it is to get HPV vaccine in low-resource settings. And what we saw, this is before COVID, this is not a COVID impact, was that in 2018, there was this marked increase in desire to get HPV vaccine, especially around countries that get what's Gavi funding. Now, Gavi is a group that funds vaccines to the poorest countries in the world based on their GDP. There's 52 countries they fund vaccine for, and they fund the HPV vaccine. So a lot of these Gavi countries said, hey, we want to give this vaccine. These are the countries with the highest cervical cancer burden. If you remember back to that first map that I showed you of the dark colors in Africa, and many of these countries are like, let's roll out the HPV vaccine. But then what happened is that there was this massive global supply constraint. The HPV vaccine up until recently has been almost all by a single manufacturer. They had some plant problems. They had some decisions to make about who was going to get vaccine, and Gavi pays $4.55 a dose, and CDC pays $160 a dose. So just like COVID vaccine, this is vaccine economics. And it's estimated that 34 million girls who were planned to get this dose between 20 and 25 missed out because of this global supply constraint. Now, in these lower income countries, because they don't have screening and because they have such a high burden of disease, you only need to vaccinate 70 girls, for instance, in Ethiopia, to prevent a case of cervical cancer. At the same time that this massive global shortage was going on, we upped our age to 45 in this country. And I was in that committee, I was in those discussions, and I understand why we did that. But what they did show in that meeting in 2019 is that you have to vaccinate 6,500 40-year-olds to prevent a case of cervical cancer. So I'm a gynecologist. I have a lot of 40-year-olds, recently divorced, come to me. They say, should I get this vaccine? And that's an individual conversation with them. And what I say is, let's think about what your risks are and so forth. And I say, yeah, it may serve you well. And what I say to the rest of us is, I don't have the choice to send this vaccine from this girl, this woman who's 40, to Ethiopia. I don't get to make that choice. But what I get to do is educate and advocate and say vaccine equity is really important and we need more supply. And so that's why I bring these numbers up. Now, we are doing better. In 2023, 27% of girls globally had a single dose. So will we reach 90% by 2030? Probably not. But there really is a good upward trend going on. This was 13% during COVID, okay? So this is a huge increase. What's really hard right now is that the country's, quote, caught in the middle, meaning they don't qualify for Gavi funding for vaccine because they make too much money. For instance, Namibia is one of those countries where I've worked. But they can't afford the cost of $11 or $13 a dose or whatever they can negotiate with a supply person. So there are so many countries right now that still have no hope of rolling out this vaccine. And the supply issues still occur. This just was in the New York Times last April. Once again, Merck had said to Gavi, we're going to give you X number of shots. Instead, we're going to give you 29 million doses so that all of these countries like Ethiopia can roll out the vaccine. But then they could only deliver 18. So they were 10 million doses short. So this is an ongoing issue. And the good news is we are getting much more supply. China has 2 HPV vaccines now in production that have been WHO pre-qualified. India is really close to getting one. And all of this increased supply will help markedly, globally, but also help push the price down. I was in Pakistan in August where they were applying for funding to get the HPV vaccine, which they did get. They're using one of the vaccines from China, and they are starting to roll this out this year in phased approach, and they're going to vaccinate over 10 million girls against HPV vaccine. So where are we in our country? Again, we have our mixed picture. The high is Rhode Island, where they have a school mandate for HPV vaccine, and they have over 95% coverage. The low is Mississippi, which has 38% coverage. We're kind of in the middle here, but what's really interesting about HPV vaccine is that unlike most health interventions where the people who have the insurance take advantage of the health intervention more commonly. This has been opposite that. So the people who are below poverty actually have a higher uptake of this vaccine than individuals above poverty. And of course, we might have our ideas and can speak to why that might be. But also the racial disparities have been very interesting. It has had the lowest uptake in Caucasian individuals and higher uptake in individuals of color. And I think that speaks to what I showed you earlier about the cervical cancer rate in rural areas climbing up to 5% a year in white individuals compared to African Americans or people of color. Now, of course, they have higher cancer rates overall, but if you look at where it's really increasing, it's increasing the most right now in Caucasian individuals. How about the state of Washington? I pulled this up a couple days ago in our health department data, and this is vaccine in 11 to 12-year-olds, which is the target age range. You can see there's a big variety in our counties, from 4% over here to 49% here to 45%, and so it's quite varied. And what I find really interesting is now I'm looking at 13 to 17-year-old coverage. The map before was 11 to 12-year-olds. We are now a state which has higher coverage in males than females. So we actually have 67% of our 13 to 17-year-old males getting the vaccine compared to 63% in females. And of course, I have 2 sons. I've vaccinated them. I think it's good that males are getting the vaccine. I find it interesting how quickly it picked up compared to the slog it's been and now the plateauing in females. And, you know, again, we can think about why that might be. But we are definitely seeing a wonderful thing happen in our country. Even in our country that's been so slow to uptake HPV vaccine, we are seeing cervical cancer cases drop in our youngest population, those that have been most likely to get the vaccine. And again, that speaks to why we really have to get this vaccine into all of our populations, our urban populations, our Caucasian populations. But this is a map that showed cervical cancer cases in people under 25. There's not a lot of cases in individuals under 25. But what happened was that there's been this really precipitous drop in those cases. And as we age, we should see this drop move further up the curve because women who got the vaccine will age and will have a decrease in cervical cancer. So that's been really interesting. And the authors of this study published earlier this year, or in 2024, a few months ago, say that, again, vaccination seems to be the only reason for this. But that, again, since COVID we haven't seen the uptake that we used to have with this vaccine. So we're still behind. But this just came out again last week. Last week was a big day, big week for news. This is really great. This is looking at CIN3, which is a precursor, of course, to cancer. It's looking at the incidence in 20 to 24-year-olds. And what you can see here from 2008 to 2022 is an 80% drop. So that is so encouraging. And it's another great reason that it's easy to message about this vaccine being a cancer prevention tool, and even in our country that has not had the uptake that Australia had or Sweden had or Scotland had, we are really starting to see the benefits. So what about messaging? Well, first of all, I always want to say that, of course, there's no one-size-fits-all for almost anything in medicine, but certainly for messaging about vaccination. And when I was doing research for a book I wrote, I came across this really wonderful example of culturally relevant messaging from the Navajo Nation, where they have this ceremony that they traditionally do of individuals when they have their first menstrual period, where they invite the aunties, the grandmas, all the family, and they have this really big celebration. And they decided to combine that with HPV education, including vaccination for the girl who's getting her first period and screening for the mother. And they have reached really high coverage and received awards for this. And I thought it was such a great example of the creative use of cultural traditions and messaging that you already have to combine it with vaccination. But I also wanted to talk a little bit of more of the, I guess, the research and the messages for how to increase vaccine uptake. And this is a model that was initially developed by Noel Brewer, who's at North Carolina, who's now on the ACIP, but then was adopted by WHO and has been talked about a lot in the last decade. And essentially, it's looking at the idea of what people think and feel, like your own I statements, what I believe, what I think is important, combined with social milieu or social processes, which is what people around you are saying about vaccines. That these two factors together equate to how you develop motivation to get a vaccine. And then you have to overcome the practical issues, like how am I going to get a vaccine? How am I going to pay for it? Is it affordable? Do I feel respected when I want to get this vaccine? And all of that leads to vaccination. So I'm going to go through this just a little bit. So as far as what people think and feel, thoughts and feelings in observational studies, like is the vaccine safe? Is it going to work? Do I have confidence in my provider? Have been shown in observational studies to make a difference. But they have not consistently been shown in the long term to really impact vaccine uptake, which is kind of unfortunate because what do I like to talk about with my patients? I like to talk about the burden of disease and whether this vaccine is cancer causing or not. And, so this I feel like is just a little bit disappointing that you can we want to impact people with data, with information, but does it really make a difference to how they feel individually? It may not make as big a difference as we would like it to. But what we do know over and over across the globe in high and low resource settings, several continents have done the same research that has showed over and over that the single most important predictor is a strong provider recommendation, which is in our power. And how do you offer that recommendation? There has also been a lot of study done on that, and there's actually this particularly really good training site that I looked at this week as I was preparing for this talk about how to message about the vaccine. It is geared toward pediatricians. And they have found that in offices, when they studied using this type of messaging, they actually had an increase of up 5% uptake in the HPV vaccine. And this was replicated in the US and the UK. And it was just the idea of trying to announce versus ask. Just say, Sophia's 12, she's due for 3 vaccines. Today, she's going to get meningitis, HPV, and whooping cough. And using that as a starting statement instead of whatever other options there might be. And of course, I'm eager to hear from you because you have more of these conversations with 12-year-olds than I do. And so, but what's also been shown here is peer and community thoughts are influential. I saw this so much in the COVID time, right, where I would be talking to pregnant individuals to encouraging them to get vaccines. And this is when we were in the Delta wave. We were having our labor and delivery filled with women who were on incubators and delivering babies early. And I had one woman say, I want the vaccine, but if I get the vaccine, my family's going to disown me. Or other things. And so I think we cannot always overcome the influence of peer and communities, but we can maybe try to work with it. Okay, so then looking at the practical issues here, like where is the vaccine available, ease of access. Because of these practical issues, you may have heard this big wave nationally to try to start HPV vaccination at 9. How many people here start talking to their clients about vaccination at age 9? So there actually is this whole wonderful journal article that was published in 2023 looking at various studies of 9 versus 11 to 12, and of course I won't go through those. But it is a really interesting question, and this is another thing that the ACIP HPV work group is considering. Instead of saying, give it at 11 to 12, but you can start at 9, should we just say, give it 9 to 14 as soon as you have an opportunity? And will that make a difference in uptake? And of course, these are other techniques that have been studied and shown that they work very well. Educating office staff I found at Harborview really important. So many of our office staff had no idea why we were wanting every pregnant individual to get the flu vaccine. They just really didn't know. And so I think educating office staff can be really helpful. Let's face it, they spend much more time with your MA and nurse than you. And if those people don't understand why you're recommending all these things, how can they be good messengers? So I think it behooves us to take time to work with our staff well. And then as far as resources for billing and coding, that's always a huge deal. You have to get paid for what you do. I just Googled again this week in the American Academy of Pediatrics, you have a whole ton of information about vaccine financing and coding. Obstetrician gynecologists would be a little jealous about the amount of information that you have available to you. But we're catching up, but you definitely are in the lead here. And so I think it is helpful. Of course, you have to get paid for what you do, and you can bill for having those conversations that sometimes take 15 minutes about a vaccine. That's a billable service. Well, okay, so commonly asked questions. Oh my gosh, it's been HPV Awareness Week this week. And in January was Cervical Cancer Prevention Month, and I've had a few interviews. I can't tell you how many times I've been asked, is the vaccine safe? And of course, we're going to be asked that more and more, I think, in this age. And I answer that in a few ways, but when I ask people, do you want data? And if they do, I can say, without a doubt, absolutely it's safe. We've given over 170 million doses globally since 2006. And this has been tracked by global safety agencies all over the world. And there haven't been any safety signals for long-term impact. And it doesn't have any live virus in it. No, it can't give you disease. And so, of course, if you want data, I can give you data. I also talk about, this is a vaccine that prevents cancer. And let's talk a little bit about that. Let's talk about the fact that if you get cancer of the cervix and you get even pre-cancer treatment is difficult to get a leap, to go through colposcopies and biopsies. That's really uncomfortable. It creates a lot of difficulty. If you get treatment, almost always you're going to end up sterile. You're not going to have children. And you're going to have potentially long-term impact to your vagina from the radiation that can make sex for the rest of your life really difficult. You don't want this cancer. Even if you can live through it, you don't want the treatment for this. We do have screening, and I'm not talking about screening because this is not the focus of this. And it works, but it's not perfect. And I have, again, a lot of people I know who unfortunately had a false negative screen, especially in the era of pap smears. And you do have to have not just screening, but the treatment and follow-up access, which is becoming more challenged in our country, not less, if you don't have health insurance. And of course, I mentioned the oropharyngeal cancers. So yes, you can tell it's very easy for me to go on my soapbox about this is preventing cancer. It's not the flu, it's cancer. And then, of course, what's been commonly noted in many, many studies is the importance of empathy and curiosity in vaccine discussions. I often say, well, what information have you heard and what would be helpful to you? Because I don't want to just barrage people if that's not really what they're looking for. And that's often where you can uncover some of the misinformation that people have heard, is by trying to be curious. And hopefully, if you don't get them to agree, you'll continue to plant seeds and then they can agree later. And so I want to talk just a little bit about where we are right now. I think those of us in the public health field and the global public health field, this has been a really rough few weeks. And I'm being asked a lot by, how is our new HHS chair, et cetera, going to change what we're able to do? And of course, we don't completely know the answers to that yet. We're all concerned that the ACIP that was supposed to meet last week was canceled, hasn't been rescheduled. We were supposed to discuss single-dose data at that meeting. Will we get to discuss single-dose data? We don't know. But what nobody can take away from us is the ability to do bottom-up public health. And by that, I mean peer-to-peer talking. I know teen groups working in Garfield or several other high schools that are HPV vaccine advocates working with the public health department. We can share our own vaccine stories, like, yeah, I got the HPV vaccine, it hurt my arm, but other than that, I recovered and I'm fine. We can just try to reach out within our groups. I think working with the next generation is really powerful. I had an opportunity last week at University of Michigan to speak to 180 undergrads in a reproductive justice course talking about the reproductive injustice of cervical cancer. And their questions and their interest and their passion for equity really was like, no pun intended, a shot in the arm for me. And I just feel like that is one thing we can continue to look at too, is working with the next generation. Social media, as you're comfortable with it, all of us have different skill sets about that. But we do know that every negative vaccine message is reshared 10 times more commonly than positive vaccine messages. So why aren't we putting more positive vaccine messages out there, like, oh, I just had my checkup and it's all clear, thank you, HPV vaccine. Simple things like that. And so the other thing I would just say, to me, in this time, is I think we that are working in advocacy and public health really need to stay in community and keep supporting each other, since the bad news just keeps coming. And lastly, I want to talk about story, because I feel like, as now I've been in this career for 33 years, again, COVID kind of really changed my perspective. People didn't want data. They cared about the story their hairdresser told them. And I've really come around to believing that advocacy you need data. I love data. I'm a data nerd. But stories are really powerful. And how do you try to change how people relate to a disease? It's with stories. And this is a quote by a Cherokee Nation lawyer who does social justice. I don't think any amount of data will ever change minds. It's the stories. And I had my own advocacy journey where I spent 5 years curating stories of cervical cancer survivors or family members from 6 continents, and did a lot of interviews. Did a lot of interviews of experts, and I combined it with my own experience and talked about HPV, the vaccine, cervical cancer, in a way for the general public, and ended up publishing a book that tries to offer hope-filled examples for a way beyond all the obstacles that we've been talking about. And I'm now seeking opportunity for advocacy partnerships. I've been so moved by cervical cancer survivors who are willing to tell their stories so that other people don't have to suffer the same fate. I've been on panels with anal cancer, penile cancer, throat cancer survivors. And I think these stories are really important. But it doesn't have to be cancer. It can be all kinds of stories, because I really think we can't afford to have science silos right now. We need to message in a way that combats stigma by using story. And so I feel like you put data and science together with advocacy and stories, you hope for change. This is the book I wrote called Enough Because We Can Stop Cervical Cancer. And it's mostly centered on women's stories from around the world with information behind it. But I would close by saying, I usually talk about cervical cancer. I also feel strongly, of course, about other HPV cancers. But we can do something about this. We have the power. You have the power. You are the bottom, rung here, trying to get every kid vaccinated before they get exposed to HPV, if you can. And with that, I'll close, and I'll be happy to take questions. And then here's my website and my Instagram. If you want, follow me on Instagram, and here's the website. It has a lot more information about HPV if you're interested.
Thank you so much. Oh, wow. Hi, everybody. Raise your hand if you have a question. I'll hand you this microphone. And if you're online, you can type your question, and I will read it out. Thanks.
Thank you so much for coming and talking to us about this. I was wondering if you could speak a little bit to where we're at in terms of changing the guidelines to move towards 9, because I think a lot of the data shows that there's improved vaccine uptake and improved kind of immunologic response at that younger age.
Yeah, thank you for that. And I think, how ACIP works in our country, ACIP obviously makes recommendations to CDC, and CDC usually ratifies them. Who knows what's going to happen now? But one of the questions, and ACIP forms work groups of people to look at the data that then talk to ACIP to make the recommendations. And I'm on the HPV vaccine work group as a representative for the American College of OB-GYN. We have been talking about 9-year-olds and how to change the language. That is a decision that ACIP hopefully will vote on, and I don't know when.
Hi, Dr. Eckert. Thank you again for the presentation. My question was, you said that circumcision can also help prevent certain HPV virus cause cancer. And what age range is that most effective? Obviously, it becomes more complicated the older you get.
Yeah.
I was wondering if you had any data about that.
Yeah, you know, that's a really good question, and I don't remember those specific studies really looking at teens versus adults. But as far as, you know, HPV transmission, it would be the teenage years. I think that a lot of the voluntary male circumcision projects in, you know, Uganda and all the places that we've read reports on took males of all ages. And with HIV, which doesn't need this 15-year incubation time to go from virus to cancer like HPV does, you know, vaccinating or circumcising at 40 has much more direct impact. But you raise a good point that if you're going to use circumcision, the best would be to use it at a younger age.
Any other questions from our group? All right, if not, I'll say thank you so much, Dr. Eckert. This was so informational and also really, really inspiring. So we appreciate your time and all of your research. Thanks, everybody.
Thank you.
See you all next week.